evening, everyone, and welcome to tonight's lecture on subcutaneous immunoglobulin administration. My name is Brittany Isaacs, and I am a graduate student at the University of Maryland School of Nursing. Tonight, our objectives are as follows. At the conclusion of this activity, the learner will be able to discuss autoimmune disease, describe examples of autoimmune disease, explain treatment for the autoimmune diseases, define subcutaneous immunoglobulin, and demonstrate the steps to administer subcutaneous immunoglobulin. So let's start off by talking about autoimmune disease, because without that we would have no treatment with subcutaneous immunoglobulin. So autoimmune disease is a disease that occurs when our bodies start to attack themselves. Our immune system begins to attack healthy cells and cause havoc on the patient. So the patient doesn't know the cause, usually it's unknown, but there are some things that can be attributed, such as our infections. If we've been exposed to certain things, they can be attributed to autoimmune diseases. Unfortunately, the patient, once they have one autoimmune disease, they are susceptible to acquiring a second or a third autoimmune disease. With many of those situations, the patient's treatment modalities do kind of coincide, so we are treating multiple autoimmune diseases at the same time, which is a benefit as far as treatment goes. So these patients are at risk for infection, and usually their immune systems are compromised and with the treatment modalities, so they are susceptible to greater infections and they need to take precautions. We do not have like I said, the cause for these autoimmune diseases, and many times it's hard to really pick up on what's going on with a patient. So it's little things that we can do to assess a patient and say maybe we should dive into autoimmune disease testing. And usually that's done with a rheumatologist or a neurologist. So some examples of autoimmune. Now there are over 100 autoimmune diseases, and we are investigating and discovering many more of these in the United States. But these are just a few that we're going to talk about. So we have CIDP, we have Guillain-Barré syndrome, or GBS, we have myasthenia gravis, and we have myositis or dermatomyositis, polymyositis, or necrotizing myopathy falls into the myositis category as well. So for many of those autoimmune diseases, like I said, the treatment modalities are similar or overlap. Tonight we're focusing on immunoglobulin. However, you would see patients with autoimmune diseases on steroids. You would also see them on immunosuppression therapy, as well as other biologics, and some cancer drugs are actually treating autoimmune diseases. So with subcutaneous immunoglobulin, here you see on the screen that we have a small needle into the fatty tissue, similar to an insulin syringe, versus the traditional immunoglobulin administration with an IV or a port or a central line. So with subcutaneous, like I said, it's administered into the fatty tissue. So what are our sites for that? So there are various sites we can use for the sub-Q immunoglobulin administration. So the primary ones that are used in most of our patients are going to be in their thighs or their abdomen, because those are easy to access. Additionally, you can use the flank area and the back of the arms. But those are not as common. They're a little harder to access, and they can hurt a little bit when the patient's sitting in a chair or laying in bed. So with sub-Q, subcutaneous IG, sub-Q, the supplies that you would need and the steps that you would take would be you would gather the supplies. One, review your orders and make sure it is current, you have the right patient, right route, right dose. And then we would gather a syringe pump. The greatest thing with the syringe pump is that there's no batteries, so we no longer have to troubleshoot or have patients who are not as tech savvy use them. These are a spring-loaded pump. So here in the picture, you'll see the syringe pump. You'll also see the medication, the administration set, which has 4 needles, 6 needles, 8 needles, depending on the patient and how many sites they need to use. You also see the flow rate tubing, the syringe, as well as a vented spike. So it looks like a lot of supplies initially, however, it's mainly just packaging. Once you walk through it a few times, it becomes second nature. So we're going to watch just a quick video on Hizentra, which is one of the subcutaneous immunoglobulin therapies on the market today. And then we'll just make it bigger so everybody can see it. So we'll just watch this quick video and then we are going to do our own. So the great thing about the Hizentra is that the products, they come with these really nice tutorials for patients. They come with a nice app, and I can show you, pass around my phone because I don't have it on the screen, but I can show you the app. And they really have made it user-friendly and patient-savvy. Okay, so now, we are going to do a case study, and then we're going to do a demonstration with the products. Just a moment here. Go back. If you minimize that screen, you can get back to the PowerPoint. All right. So we have a 32-year-old female whose chief complaint is blurred vision or ptosis, which is droopiness of the eye. And those are her chief complaints, so double vision and ptosis of the eye. When we're looking at that, what would we think her disease might be? So we may be looking at an autoimmune disease. Myasthenia gravis is one of them that would cause double vision and ptosis of the eye. So if we were going to treat her, we would treat her if she was a newly diagnosed patient, usually with steroids. But she is not a newly diagnosed patient. She has been under the care for some time now, and we are looking at other treatment modalities to help with her ptosis and double vision. So with that said, we may consider Hizentra or another sub-Q IG product to help her, because we know that IG helps with the autoimmune diseases. So we are going to do a quick demonstration with the products, and these are just the sources that I used in making this presentation. So I do not own rights to Hizentra, but we are using their product tonight. So of course we would wash our hands and review our orders. So we have our orders here, we would review them, make sure we have the right patient and the right medication. We would inspect our medication for the expiration date. We'd make sure it was a clear solution, no particles floating around. We would also then, we would check our EpiPen. Every patient on the product would carry an EpiPen in the event that they had an anaphylaxis reaction. And so we would have that out, make sure it was in date. So then we would take our 60 cc syringe and we would connect it to our vented spike. The nice thing about the vented spike is that we no longer have to force air into a glass vial. The air would escape through the vent. So then we would pop the top. I I just remind patients to alcohol swab the medication just in case they touched it. So we clean the site there. Always make sure that you have the vial down on a hard surface because it is a little hard to press in. Then we would draw up our solution. IG is a little thicker. I'm using just normal saline for the demonstration because I would not want to waste the product. It's very expensive. Remind patients that this is a blunt object. It is a needle, plastic needle. For tonight's purpose, I will recap, but usually we do not promote that. So then you take your administration tubing. This controls our rate. So we're going to connect that. Now it's very hard to push through this because this is driven by the pump, but you can lead the line or prime the line, if you will. So then this tubing gets connected to our administration set. Now with Hizentra, they do not require the patient to prime the line. They do ask that it be a dry needle. A dry needle just simply means that there is no solution coming out of the tip of the needle because IG is irritating to the skin. So in the event that a patient did prime it all the way and IG came through the needle, I ask them to wipe off with an alcohol prep before administering it to the skin. So now we're connected. And these are needles here, so I'm not actually going to insert. But the tubing is long. You would connect your syringe into your pump here. So it is like a wind-up toy. Easy to use, patient friendly. So once it's in there, we have an on-off switch, really easy. We would do that after we connect our needles. So our needles would you just simply take back. The little wings help for guidance. And again, this is a real needle, so I have to be careful. So we would do insert at a 90-degree angle into the fatty tissue, and then we would fixate it with a Tegaderm. And then we would do as many sites as we required for that patient. And then once all the sites are in, you would turn the pump on. And it will make that noise, but only until the piece meets the plunger. And now it's administering slowly. So roughly you get 25 mLs per site is the guidelines. Not all patients require that. It depends on the dose, but that is what it is, the amount per site, and that's just because of absorption. It does take about 24 hours to absorb, but that's not a massive lump under the skin. It's a small lump, but we do make any notes if the patient experiences a reaction, skin irritation, side effects. Usually those are very minimal, but they can happen. So we do have patients record in a journal or on the, I can show you all the app. So the Hizentra app is here, and it does have the tutorial. It does have a journal where the patient records their sites, their dosing. They can scan the expirations, and it makes it really easy to use. So I'm going to go ahead and pass this around. And then also tonight I have some literature for you on CIDP as well as myositis, MG, so that you can just kind of understand autoimmune disease and what the patients are going through, as well as the treatment modalities. If we have any questions, or if anyone else would like to come up and see the supplies here, or if they would like more information, I'm more than happy to talk about it or walk through it again. But if not, that concludes our presentation, and I hope you all have a lovely night.